event for future reference. Questions may be submitted to the faculty at any time, and selected questions will be addressed with responses provided during the Q&A portion of the program. At the conclusion of the event, educational credit can be claimed by clicking the Earn Credit link on the side panel or scanning the QR code. Presentation slides will be available for download immediately after the session using the Medscape Live app or by logging into your account at medscapelive.com. While you're on the Medscape Live app, you can explore and register for upcoming events. Thank you again for joining us. Our program will begin shortly.
Good evening, everybody. Can everybody hear me okay? Good. Okay. Well, it's great to see everybody. My name is Earl Hirsch from the University of Washington, and welcome to tonight's meeting, Breaking the Routine, Modernizing Mealtime Insulin Management in People with Type 1 Diabetes. I don't know about the rest of you, but this has been quite an interesting ADA meeting so far. We're only about halfway through, and hopefully tonight you will also find interesting. Tonight's meeting is supported by an independent educational grant from Mankind Corporation. And we want you to use your own technology. We are offering an interactive experience during this live event. When joining on your personal device, you can view the slides, access today's content, ask questions, and participate in polling. And we will give you time to join before the program begins. We do have Wi-Fi in here if you need it, and you can see the password. And we will be having interactive questions over the course of the meeting, and hopefully everybody will participate with that. So, tonight again is Breaking the Routine, Modernizing Mealtime Insulin Management in People with Type 1 Diabetes. Again, I'm Earl Hirsch from the University of Washington in Seattle, and I am happy to report that today the Mariners beat the Tigers 4-0, so we have another reason to celebrate. Yep. My other faculty, Dr. Mike Haller, who's professor and chair of pediatric endocrinology at the University of Florida in Gainesville, and my Missouri Tigers will be playing Florida first weekend in October. And my other faculty colleague is Diane Isaacs, who's a PharmD and Director of Education and Training in Diabetes Technology at the Cleveland Clinic Endocrinology and Metabolism Institute in Cleveland, Ohio. So welcome to both of you. And what we are going to do now is we're going to do a live clinic to try to represent and show what happens probably for most of us. The first scene will be the patient perspective overcoming insulin adherence gaps. Then Diana will talk about the clinic in action and team care. And then Dr. Haller will talk on the follow-up visit, safety monitoring, and as noted, we will have panel discussion, audience Q&A as we go through. So, patient presentation. Our patient is a 19-year-old male patient with type 1 diabetes presenting to the endocrinologist to go over yearly labs at his AGP report. Before I go any further, please raise your hand if you're a pediatric endocrinologist or you see pediatric patients. I like to know my audience. Okay, raise your hand if you just do adult care. And raise your hand if you do both, if you see these adolescents. I'd always like to know. Very good. Okay, so we're going to go over the AGP report. This is a college student, and he has recently transitioned to an adult endocrinologist. He has had diabetes since childhood. He is having trouble managing mealtime insulin dosing. You can see his medications. He takes Degludec. He takes insulin Lispro. Before meals, his total daily dose is 0.73 units per kilo. He uses a continuous glucose monitor. His exam is unremarkable. His A1C is 8.2, his BMI is 28, and his weight is 180 pounds. His AGP report shows post-meal spikes, often over 250, 2 episodes of level 2 hypoglycemia in the past 2 months. This was my debate topic yesterday, level 1 and level 2 hypoglycemia. Maybe there will be questions on that at the end. His time in range is 58%, time below range is 2%, time above range 40%. His glucose management indicator, or his estimated A1C, is 8%. He has a carb ratio. He has an insulin sensitivity factor, as you can see. And so let's go to scene 1 from the patient perspective, overcoming the insulin adherence gap.
Hey, Zach. It's good to see you again.
Hey, you too.
How are things going with school? Last time you were a little stressed handling all the changes.
Yeah, it's going better now. I have the hang of things and my classes are keeping me pretty busy.
Okay, well, that's good to hear. I have your lab results, and I was looking over your AGP report from your continuous glucose monitor. Can we review the results together?
Sure.
So your hemoglobin, A1C is 8.2%, which is slightly improved from 3 months ago when we switched your mealtime insulin. It was 8.4% then. I can see you're spending about half your time above the target glucose range, with some significant spikes after meals, some over 300. How has your insulin routine been going?
Yeah, honestly, it's been really hard. I don't always take my mealtime insulin on time. Sometimes I forget it in the dorm if I'm going out with friends, and I'm afraid my sugars will go low, especially after I work out or when I'm sleeping.
I see. Well, can you estimate how often you do take it with meals?
I might miss a few doses a week because I'm running around and forget. Breakfast is fine, but lunch and dinner are tougher. I'm just too tired to deal with counting carbs and calculating doses, and I'm afraid I'll give myself too much if I take it before I eat.
I understand. I can feel like a lot, and hypoglycemia can be scary. I see you had 2 instances of blood sugar below 54 in the last 2 months. Do you remember them?
Yeah, one time was after the gym, and another was in the morning. I just hate that feeling.
It can be very scary. Given these challenges, have you considered an insulin pump or automated insulin delivery system that works with your CGM? Could help prevent hypoglycemia and reduce some of that decision-making burden.
No way. I really don't want a pump right now. I'm finally dating someone, and I don't want something attached to me all the time. People might see it and ask questions, and I already have to answer them about CGM, and that's hard enough.
I understand those concerns completely. There are a few options we can consider besides pumps. One possibility is inhaled mealtime insulin. Have you heard about that before?
No, I haven't. Like an inhaler?
Yes, exactly.
No, I didn't know about that. Could I use something like that?
Well, before we discuss it further, do you have any history of smoking, asthma, or lung problems?
No, I've never smoked, and no lung problems or anything like that.
Great. Well, let me tell you more about it.
Okay, so here's our first polling question. In the INHALE-1 trial, which outcome was observed in pediatric patients using inhaled insulin compared to subcutaneous rapid-acting analogs? A, greater weight gain, B, higher incidence of severe hypoglycemia, C, less time in range, or D, similar hemoglobin A1C. And you can join with the QR code on the right. Okay, the most common answer, and you got it right, similar hemoglobin A1C. So congratulations. And let's look a little bit more into the data we have. So AID, which is automated insulin delivery, I think everybody here knows this, and this is from the American Diabetes Association standard of care. They are the preferred insulin delivery methods over multiple injections, insulin pump therapy without closed loop, and sensor-augmented pumps in people with type 1 diabetes. The evidence of that is very clear, and the ADA gives that level A evidence, the highest level they have. Also the same for adults with type 2 diabetes, that's also level A evidence, and children and adolescents with type 2 diabetes. Now, we don't have the randomized controlled trials for this last group, so that's considered expert opinion, level E evidence. Still, our AID systems are far from perfect in normalizing postprandial glucose spikes. This is actually a patient of mine. Now, this was a patient who actually eventually went into the INHALE-3 study, the adult study, and this is with the Medtronic pump, and you can see that his glucose levels were far from perfect, and he actually came into the INHALE-3 study, and to this day he remains on Technosphere or inhaled human insulin. This is from Dr. Kristen Norgard at the Steno Clinic in Copenhagen, and I want you to pay attention to the far left when she looked at this cross-sectional group of 3,184 CGM users, and 1,600 of them were on MDI. You can see their time in range was 54%. And now if you go to the far right, looking at the AID users, the time in range was 71%. And this was, a retrospective look, but this is what we see in our clinics every day. And I think we're all convinced, both on the real-world evidence and the randomized controlled trials, how much of an improvement the AID systems have been. Still, the patient says to us, no way, I really don't want to pump right now. We all hear this. And in fact, the rate of insulin non-adherence is from 23 to 77% in adolescents and young adults with type 1 diabetes, and about 59% in adults with T1D. So it can be intentional or non-intentional as far as this non-adherence topic is concerned. So not everyone wants a pump. We all acknowledge that. What other options are possible? Well, this is one of the earlier pharmacodynamic studies where patients are injected insulin, or in this case, they have inhaled insulin with the TI, which is Technosphere insulin, and you can see the insulin action by the GIR, the glucose infusion rate. And you can see with the Technosphere insulin, the greatest amount of activity is less than an hour, and then you can see the insulin wane almost to negligible at 120 and negligible at 180 minutes. It's completely gone. Now look at the 8 units of insulin Lispro. You don't see that actual peak until 90 minutes or so, and there's a little bit of a plateau. But more importantly, at 180 and 240 minutes, there is still a lot to that tail of insulin, and there's still a tad of insulin at 300 units. And I just want everybody to think about the insulin action time and the IOBs we use on our pumps, where we'll set it at 2 hours or 3 hours. That's not really the true insulin action time. Every study shows this when you actually look at the insulin action time. So the inhaled insulin maximum serum insulin concentration, it's 12 to 15 minutes compared with 45 to 60 minutes for the rapid-acting insulin. And the inhaled insulin effect dissipates faster, potentially reducing post-meal hypoglycemia. And this becomes particularly important for people who exercise. They know it's safer. At least this is what we are told. And this is why a lot of our patients decide to use this therapy. Now, I mentioned INHALE-3. Without getting into a lot of details, notice that about half were using AIDs, half were on MDI, and at the time in our clinics around the country, most were using the Control IQ, although there were some Omnipod 5 and MiniMed 780Gs, which were just released. And the bottom line, it's kind of boring. There was no differences in the TI group between baseline and 17 weeks, with usual care, also showing the A1C. And if this is all you are looking at, you would say, well, it's not inferior, so what? Well, there is a so what. And unfortunately, this is part of the paper, but it's a supplement. But I think in the supplement of the paper, if you do look it up, you should look at this and look at the other supplemental figures and tables. Because if you look at the TI, the inhaled insulin on the left, you can see half of these people are quite good responders, and they responded great. But there were also some non-responders, and you can see, I was hoping that the pointer worked, but you can see that there was one person who actually had a 3% A1C worsening, increasing. So, but if you look at it as a whole, for the whole population, there was no change. Whereas with usual care, you have this very tight bell-shaped curve, also with no change, even though they were in a clinical trial. So there are people who are great responders, and there are people who are not responding at all. They actually got worse. So what about the 45 of the 58 people who remained in the inhaled insulin for the additional 13-week extension phase? And when we look at it, there was this, you can argue, clinically insignificant further improvement of the A1C by 0.2%. And I suspect this is because as people during the actual trial were getting used to it and getting better, it wasn't captured at the end of the 17 weeks, but by 30 weeks, the entire improvement in glycemia was seen a little bit. Nevertheless, we see that at the start of the randomized controlled trial with inhaled insulin, with degludec was initiated at baseline. I need to point out very quickly, it's important to use a really good basal insulin and know how to titrate basal insulin. If we have time to talk about that in the Q&A, we will. We felt at the beginning of the trial this was the best basal insulin. I still feel that way for type 1 diabetes, and so this is what we did. So what about safety issues? Well, hypoglycemic episodes, insignificant difference between treatment and control group. We're going to hear more in a minute about FEV1 on the pulmonary side. Insignificant difference between treatment and control group. No participants had an FEV1 decrease greater than 20%. The prefixed level for an adverse event, we did not see that. We did see cough in 23% of participants, and in all of the TI studies, this is the most common side effect. And I want to point something out that just went online recently, looking at real-world data of Epic Cosmos patients. And Epic Cosmos looks at 300 million people on and I want you to note at the bottom of the table, there was no there were no cases, not even one case of lung cancer in the Technosphere insulin group, and there was more COPD, however, in the control group, and that makes sense because COPD, if you have emphysema or chronic bronchitis, that is really a reason for not taking the inhaled insulin. So this was very reassuring, having this huge database and not seeing a cancer or COPD signal. Now, very quickly to Dr. Haller's study, INHALE-1, which was recently published, looking at the primary endpoint at 26 weeks. You can see this tiny increase in the TI group, whereas there was no change in the rapid-acting insulin group. But the sensitivity analysis went back to look at this, and by excluding one extreme non-adherent outlier, that resulted in a 0.14% difference in A1Cs. And so that did become significant. If that outlier was taken away, like in INHALE-3, there was no difference in A1C in INHALE-1. So other conclusions from INHALE-1, no new safety signals were identified. There was less weight gain and increased parent and patient satisfaction. And inhaled insulin may represent an alternative option for appropriately selected youth with type 1 diabetes. And important to note that just very recently, within the last week or so, the FDA approved inhaled insulin for children and adolescents aged 6 to 17 years old with type 1 diabetes or for type 2 diabetes, and we are seeing more type 2 patients in youth. So for patients with type 1 diabetes, of course, inhaled insulin must be used in addition to a basal insulin. Key considerations for patient selection for inhaled insulin. First, of course, is lung disease, as I mentioned. It's contraindicated in patients with chronic lung disease, such as asthma or COPD, because there can be bronchospasm. Smoking is not allowed. Inhaled insulin is not recommended for smokers because it makes the insulin even faster. And finally, cost may be an issue for some people. Coverage and out-of-pocket costs may vary and can certainly influence treatment selection, and we see that all the time. Some other practical tips, and I wish we had more time to talk about this maybe in the Q&A. Periodic in-office pulmonary function testing is recommended after 6 months and then yearly after that. Watching the CGM, the patients need to know, and what we do is we put a lower alarm threshold to indicate dosing between meals and at bedtime if needed. And that was the secret, is giving these between meal and bedtime doses, especially for high carbohydrate and high protein meals. We do not ask patients to count carbohydrates. Patients generally learn how much they need for meals and corrections with following the CGM. And finally, maybe the most important thing is minimizing exercise in that first hour or 90 minutes when you have those very high insulin levels. But having said that, exercising more than 2 hours later, patients tell us how much better they do without the hypoglycemia they saw with that long-acting tail I showed you with the insulin Lispro. So let's go to scene 2, the clinic in action, team-based care.
Inhaled insulin has some features that might help with your concerns, though it also has limitations. For some patients, it can reduce the pressure around administration, timing, and carb counting.
That's good. I've never gotten very good at counting carbs.
And because it has a fast onset and offset of action, we believe it's less likely to cause those delayed low blood sugars you've been experiencing, especially overnight.
Really? That's the main thing I've been worried about.
Yes, but first, we need to check your lung function with a simple test called an FEV1 test.
Okay, what do I do?
Just take a deep breath in, blow out into this device as hard and fast as you can. Perfect. Let's try it one more time. Good. Your FEV1 is normal. Great news.
Cool, so I can use the inhaled insulin?
Yes. I'd like to show you the inhaler and how it works. These are insulin cartridges that go into the inhaler. They come in different doses, which are color-coded. That's it. The diabetes nurse educator will teach you how to match them to your meals. And one important difference with inhaled insulin is you take it right at the start of your meal, not 15 minutes before like with injectable insulin, because this works faster.
Okay, that makes sense.
If your glucose is running high after meals, we have you take an additional inhaled dose based on your CGM readings. For instance, if you're eating lots of fat and protein, your glucose may be high 2 to 3 hours after eating.
Okay.
And again, the nurse will go over the dosing with you and make sure you feel comfortable. And you can call us anytime if you have any questions.
Got it.
Now, just like with any insulin, there is still risk of hypoglycemia. So make sure you have glucagon and snacks available like you do now.
Okay.
You'll store the cartridges in the refrigerator like your insulin now, and you'll switch to a new inhaler device every 2 weeks, so there's no need to wash the inhaler.
Okay, sounds like I can do this.
Great. I'm going to have the nurse come in and go over all the steps with you again to make sure you're comfortable with everything.
Thanks.
All right, well, we're gonna get now into our next polling question. So we have a 19-year-old man with type 1 diabetes who transitions from 5 units of sub-Q insulin Lispro per meal to inhaled insulin. What is the most appropriate starting dose of inhaled insulin? And remember, you can scan this QR code to participate. Your choices are 4 units, 8 units, 12 units, or 16 units. All right, so very interesting. Okay, so the best answer here is actually 8 units. And let's kind of talk through this. So generally what we do is we can double the dose when we go from sub-Q to inhaled insulin, but we generally round down to the next available cartridge. So in this case, it would be 8 units. So this is good. This will be good learning for all of us, and we'll go into a little bit more detail on kind of how the dosing works and everything. Before we do that, though, I do have a reflective question for you all to think about, and that is, what have been your challenges when a patient requests a non-injectable option that is outside your standard prescribing routine, right? And inhaled insulin, some people are surprised to find out that it's actually been around for a while, I believe since 2014. But many of us have not been as familiar with using it and starting it in our patients. I think one of the reasons why is probably, how do you dose it, right? It is different than sub-Q insulin. And I'm going to take us all the way back to the Affinity 1 trial. And this was really kind of that hallmark pivotal trial that got inhaled insulin approved. This was a randomized controlled trial with 174 people in the inhaled insulin versus 171 in the sub-Q insulin aspart. This included adults with type 1 diabetes. They had A1Cs between 7.5% to 10%. And in this trial, they showed that the inhaled insulin was basically non-inferior to the insulin aspart. And you can see the A1C changes there and the average daily dose. But one of the interesting things about this trial was that they actually used a much lower dose than the current dosing recommendations. And we have found over time that to be the most successful with inhaled insulin, we actually want to use a higher dose. And to put it in perspective, the Affinity trial really used doses of about, it ended up being probably about 1.3 times higher. It was more of a 1-to-1 with rounding up to the next dose. And we now know that using a higher dose can get people to goal faster. Additionally, when we compare that trial to the more recent Inhale 3, the way glucose was measured was very different. That trial was looking at glucose levels really just the daytime. And now we're taking advantage of CGM. We're looking at not just daytime, but also nighttime. And then additionally, Affinity 1 compared to MDI users only versus Inhale 3 looked at MDI and AID users. And so really the Inhale 3 allows for a more direct comparison and better understanding of how the current dosing should be. Now, backing up, what are some other reasons we would want to consider inhaled insulin? So we talked about AID. AID is great. It is great, but some people have major issues with their skin, right? So people who've been injecting long time, people that have been using pumps and using their sites a long time develop lipohypertrophy. And this scar tissue can really impact the absorption and lead to erratic glucose levels and can be very difficult to get to goal. Additionally, many people like the idea of being detached. We saw from our patient this idea of not having something connected to your body all of the time. And then the injection burden of multiple daily injections is really hard. I mean, I think about a meal like this, right? You're getting your food. When are you going to give? You see the food, the buffet's right there. Are you really going to get here and you're going to give your insulin? Where are you going to do it? Are you going to do it in front of everyone? Are you going to go somewhere and then wait? It is a lot, right? And this leads to people missing doses, unfortunately, and not taking all of their doses. And of course, that leads to suboptimal glycemic outcomes. So coming back to the dosing, a really simple way to remember this is just take the current dosing, multiply by 2, and then round to the nearest cartridge size, but round down for safety generally. So how do the cartridges come? They come in 4, 8, and 12 units. The 4 are blue, the 8 are green, the 12 is yellow, and you can do 2 4s, you can mix and match based on the needed dose. One of the clinical pearls is that it can be pretty common when you first start using inhaled insulin, because it's a dry powder, that people may cough. Usually with continued use, people get used to it, you can have a sip of water, but in the beginning, you're not used to it and you can cough. And sometimes people find using the smaller cartridges can really help, because then it's less powder at one time. So I like to err on the side of, let's start with smaller cartridges, and then over time, if you want to go to the larger cartridges size, we can totally do that. So we also heard from Dr. Hirsch about correction doses, and people that have the most success with this, they are not afraid to do correction dosing. They can set the high alert on their CGM so they're ready. And how do we advise people though how to correct? Well, there's different ways to do it, but similar with injections, we often may give people a correction scale to follow. So this is an example of a correction scale that you could start with to follow. And so if the glucose 1 hour after eating was between 151 and 200, a person could do that 4-unit cartridge. If it, let's say it's over 200, 1 hour later, maybe do the 8. If it's 2 hours later and it's over 200, we may consider doing 4. And when you think about this, this is pretty incredible, because with injections, what we've been advising people is to wait 4 hours between doses, because we are so worried about stacking and hypoglycemia. This is really the opposite. We're saying, no, you can take action. You don't have to sit on your hands for 4 hours. In fact, we want you to correct. You absolutely can correct. What about the safety information? So the good news is that there was no significant safety concerns across 13 clinical trials in people taking inhaled insulin. And you saw from the demonstration, the FEV1 test can be used to measure lung capacity. So we do expect in healthy individuals, total lung capacity ranges from 4 to 6 liters. And one of the things one of the common questions I get is, well, what if I have a cold? What if I have an upper respiratory infection? That does not actually impact the absorption of inhaled insulin. But I do want to point out that there is a warning, the risk of acute bronchospasm in patients with chronic lung disease. And this is why we ask if a person has a history of COPD or asthma, we do not use this. We offer other options, but we don't use inhaled insulin. Now, how does this FEV1 monitoring work? And I'm so glad you got to see how simple and straightforward this is, because I hear this from my colleagues, like, what? I don't know, like I need to refer to spirometry. How am I gonna get that? This is gonna take a long time. Is this test gonna be expensive for people? No, you can have the device in your clinic. In fact, we have several in our clinic, and it is something we can do right there at the visit if we know we're going to start it. In fact, you might be wondering, well, what if you're seeing someone virtually? Then how do you facilitate the test? We have been able to get them mailed to people so that they can do it on their own. They can blow into it. We record it, and then we put that in our note, and that way, if you need to submit that prior authorization, it's in there. You have that documented. Now, you want to do it at baseline, then again at 6 months, and after that, it is just annually. Now, what about the patient education? So this is where really having that team-based care, right? You've got someone, maybe it's your nurse, maybe it's your diabetes care and education specialist, maybe it's your pharmacist, right? But you can go through that time to talk about, well, how do we go ahead and use this and inhale this? And you can have demo devices in your clinic with the demo cartridges. And I like to have my patients practice with me, practice putting the cartridge in and then going ahead and inhaling. And in fact, there is actually a device called the BlueHale Pro that you can have for your clinic. And you can use this and pair this to a smart device, and it will actually show if a person's technique, if they're breathing in the right way, if they're breathing in long enough. And so that can be really helpful. If you do that one time, learn the right technique, and then it can be, easy moving forward with that. And then in terms of storage and everything, so when you're not using them, you want to go ahead and any extras you have, go ahead, put those in the refrigerator. One fun fact is if it does freeze, it's not the end of the world compared to injectable insulin where you really don't want that frozen. And then when you're ready to use it, just like other insulins, it is best to allow it to warm up to room temperature. The open packets that you have can actually be at room temperature. They can be out in the open for up to 3 days, so a person can carry as many as they need and they plan to use in the next day or two. And then the unrefrigerated sealed packets can actually be at room temperature for up to 10 days. You get 2 inhalers per month, so the idea is that every 15 days you replace your inhaler, and that way you don't have to worry about disinfecting it. You just discard it, and you can go ahead and use a new inhaler. And with that, now we'll turn it over to go ahead and watch scene 3.
Hi, Zach. How are things going with your inhaled insulin?
Pretty good overall. I'm using it more than I used to use the injectable stuff. I'm still not clear on giving myself additional doses when my glucose is high after meals.
Okay, we can go over that again, but I'm glad that you're using it more consistently. Do you have any other concerns?
Yeah, actually, sometimes I cough after I take it, and I'm worried I'm not getting enough insulin when that happens.
Well, I'm glad you brought that up. Coughing is actually normal and expected. Medication gets absorbed very quickly, even if you cough, so you don't have to worry about when you cough.
Okay, good to know. But sometimes my blood sugar still goes high after eating, even when I do take it.
Well, let's look at your AGP report. This is encouraging. Your time in range has improved to 65%, up from 50%. So good work there. And I do see you're still having some post-meal peaks above 250. You see that?
Yeah, that's what I was talking about.
Well, here's something important about inhaled insulin. The dosing calculations aren't always exact. It's okay to give yourself more insulin after eating if your glucose is still high. In the clinical trials, it was protocol for people to inhale extra units after meals if their glucose was still above 140. This is called redosing.
Okay, but won't that make me go low later?
Redosing after meals shouldn't cause delayed hypoglycemia because inhaled insulin has fast onset and offset. It's different than injectable insulin in this way.
I see.
Plus, you have your CGM to warn if you're starting to go low. I recommend we adjust your CGM alarms to be more sensitive to high and low blood sugar. We can set alerts for you when your glucose gets too high and add an urgent low soon alarm that gives you an early warning before it drops too low.
That sounds really helpful, especially the early warning for lows.
Great. Please stop by to see the diabetes educator on your way out, and she'll show you how to set these up on your device. And looking at your AGP report, it doesn't show that you had any hypoglycemia since starting the inhaled insulin.
Yeah, you're right. I haven't had any episodes like before.
I recommend you try giving yourself an additional 4 inhaled units if your glucose is above 160 after meals. If your glucose is above 200 after meals, and certainly if there is an arrow up on your device, give yourself 2 inhalations of the blue cartridges, 4 inhaled units each. What do you think?
Yeah, I guess I could try that. It does make me feel better knowing I haven't gone low yet.
Good. And you're doing really well with this.
Thanks. I do actually like it.
All right, well, good to hear how Zach's improving with the use of his inhaled insulin. Let's jump into our third polling question for tonight. Clinic team is designing a protocol for monitoring patients on inhaled insulin. Which pulmonary monitoring schedule is required for all patients according to FDA-approved labeling? A, weekly tracking of peak expiratory flow rate using a home meter. B, measurement of forced expiratory volume at baseline, 6 months and annually thereafter. C, complete pulmonary function tests every 3 months. Or D, formal spirometry testing only if the patient develops a persistent chronic cough. All right, excellent. So you all were paying attention to Dr. Isaac's part of the talk tonight and got this right. The best answer here is measurement of FEV1 at baseline, 6 months, and annually thereafter. As you saw Zach perform, it's very easy, it can be done in the office with a handheld meter. All right, so let's talk a little bit about how Zach's doing 1 month on his inhaled insulin journey. He's gone from a time in range of 50% to 65%, so definitely a clinically meaningful gain, but there's still work to do. He's gone from having a couple episodes of hypoglycemia to none since making the switch, so that's certainly a significant improvement. And he's reduced his post-meal peaks significantly. He was having frequent numbers up into 300 range after meals, and now they're down to the 225 range. So again, some room to optimize control with redosing, but he is improving. And the key message here to somebody like Zach, especially a teen, is that they're making really good progress, and we can talk about redosing strategies to further improve their control. It's especially important because this is just a different paradigm to think about how to dose insulin. As Dr. Isaacs mentioned, so many of our patients have been used to in the past, being told very explicitly, do not redose till at least 3 hours after the last dose to avoid stacking and hypoglycemia. Whereas with inhaled insulin, we actually want to encourage more frequent post-meal touch-ups of insulin when they're above target. Zach also brought up his main concern was cough, and that's certainly a common thing that comes up when we start people on insulin. It's really critical that you counsel patients proactively about cough being fairly common and to coach them through it so that they don't feel the need to discontinue because most discontinuations are actually before people come back for their first follow-up and often because they're worried about cough. So importantly, proactively telling them that cough is common, maybe as high as 25% of users at first. It's most prominent early on. As Dr. Isaacs also mentioned, it diminishes with time over continued use. People can actually got to its delivered area, and so it's important to tell people that the powder reaches the alveolar space in less than half a second, so it's in very quickly. A significant portion of inhaled insulin isn't delivered to the lungs, but that's calculated for in the dosing, as we talked about before. And so the key fact is that the insulin dissolves off the FDKP carrier, and that effective dose is delivered prior to the cough reflex even occurring. So again, please try to encourage your patients who are willing to try inhaled insulin. Don't stop just because they have a cough. That can happen before they come back to see you. And that's the number one reason for people to stop using insulin that's inhaled, even though it's unnecessary to do so. All right, so clinical pearl here, or a cough counseling script. We often sort of use this sort of language, and you can come up with your own when we're talking to patients before they take their first dose. So I'll often tell my patients, look, you may notice a mild cough when you use this inhaler. It's completely normal and expected. But here's the thing to know. The powder's actually already reached your lungs in less than 1 second. It's faster than your cough reflex. Your insulin's already absorbing before you cough. You do not need to redose if you cough. And so patients who are warned are more likely to continue use. Patients, unfortunately, who aren't given that warning are more likely to quit. So really doing this preemptively is key. All right, so why do these post-meal peaks persist, and what should we do about them? Persistent excursions are an invitation to redose. They're not a treatment failure. They're just a feature of a really rapid on and rapid off insulin, right? So especially when we eat meals like we're eating this evening that have a significant amount of fat and protein, we may have slow gastric emptying. We may see a glucose rise that extends well beyond the 90-minute TI offset that we're used to. On top of that, when we start patients on inhaled insulin, they're typically going to use conservative dosing. As Dr. Isaacs also mentioned, we start with this double the sub-Q dose rounding down. But many patients actually need more than that. It's not uncommon for me to have patients using 3 times their sub-Q dose. So when we talk about Technosphere insulin units, it's really important to make sure people understand that they're different equivalent doses. And because of that larger number, some patients are hesitant to give the extra dosing. Again, they've not been used to doing that in the past. They've been used to being told you might have hypoglycemia if you stack your insulin. But this insulin clears so quickly that you really don't have the stacking issue at all. And so as we saw before, you can provide patients with these redosing thresholds and make them very straightforward and quite simple to remember, and talk about using a 4-unit cartridge between a 140 and 160, 8 units above 160, or maybe even 2 of the 8-unit cartridges if they're above 200. Again, you can individualize this for patients, but you can make it fairly simple for them and just give them 2 to 3 scales to use. If they do that consistently in that 90-minute range after meals, we really find those patients are the ones that do the best with inhaled insulin. All right, so what about the actual evidence from INHALE-3 and INHALE-1 for redosing? Both these trials confirm the safety and efficacy of post-meal redosing. So if you looked at the INHALE-3 study, this was the adult study on MDI or AID, 123 patients. We saw that inhaled TI insulin significantly improved the time in range versus sub-Q. The redosing protocol showed that extra doses given if the glucose was above 140 were effective. There was no increase in hypoglycemia with that redosing, and postprandial excursions were significantly dosed with that approach. In the extension study, they also saw that the glycemic benefits were sustained long-term. In the INHALE-1 study, the pediatric effort, it was our first randomized trial of inhaled Technosphere insulin in the pediatric space. As Dr. Hirsch noted, we did show non-inferiority on the sensitivity of analysis if we excluded one extremely non-adherent adolescent patient. We also showed that redosing was very safe in the pediatric population. We had no clinically significant FEV1 changes, and fortunately, we just received the FDA approval a couple weeks ago, and so now we can be prescribing this for our pediatric patients as well. So in terms of a practical redosing protocol, like we talked about before, we kind of can use this simple 4-step framework. This is teachable in 60 seconds at the point of care. So take your insulin right when you start eating, double your sub-Q dose, round down. That's easy to start with. Number 2, take a peek at your CGM at 60 minutes, look at the value, look at the trend arrows. If they're rising or above the threshold, take a touch-up dose. Number 3, apply those redosing thresholds. And then number 4, set an urgent low so you can check it out and see if you've overdone it. Return through that cycle every time you eat a meal or snack, and patients get the hang of this fairly quickly. We definitely see that our patients that do the best with inhaled insulin are the ones who are willing to interact with the inhaler more frequently. Once people get used to that, they don't have to worry about using MDI. Many of them find it very, very appealing. All right, and then what about the hypoglycemia advantage? The short PK offset is uniquely protective now in 3 real-world scenarios that we've shown. So these are other really nice use cases for inhaled insulin. I find a lot of my patients who are using it use it for this particular list of reasons. So post-exercise lows, the bane of many of our patients' existence living with type 1 diabetes. They hate having to take their sub-Q bolus and know that it's going to cause them to go low after they exercise. With Technosphere, it's clearing before the exercise amplified sensitivity peaks, and we've seen that with data from INHALE-1 that there were fewer post-exercise lows. What about overnight or nocturnal? We have many patients who, especially parents, who are afraid to correct their kids who are high at bed because they're worried the sub-Q dose is going to drop them too low. Again, here, Technosphere has a significant advantage. You've got this 120-minute offset. Means by the time you've given dinner bolus and correction, it's completely cleared. You much reduce the risk for nighttime lows and overnight stacking. And then erratic meal times. Obviously, kids and adults eat at all kinds of times and have challenges with knowing what they're going to eat. So you've got this subcutaneous insulin risk. And pre-drawn subcutaneous insulin may cause lows if the meal is skipped or you decide that the kid doesn't like it, they don't eat everything, as opposed to TI, which can be given immediately at the start of the meal. The food's right in front of them, patients know what they're going to eat. And even if they don't do that and give it halfway through or after the meal, then the much faster onset of Technosphere insulin really does give it a major advantage in catching up for those times when you can't give insulin pre-meal. All right, what about some practical prescribing logistics? What do you guys need to know when you're talking to your office staff or pharmacist or patients. And we've talked about most of these things already, but just to reiterate them, dose conversion, again, double your sub-Q dose, round down to start with. Go to the nearest 4, 8, or 12 unit cartridge. We gave that example in the quiz of somebody who was on a 5-unit sub-Q dose for typical meals. So you would double that to 10. We don't have a 10-unit cartridge. We'd round down to 8, and you'd start there and potentially move up. Timing, again, huge advantage of being able to give your insulin right when you start the meal, not really needing to do it 15 minutes before like we tell all our patients to do with MDI, but many do not. Has really nice storage features, so you can refrigerate it or at room temperature for up to 10 days. Doesn't require any other special handling. The inhaler, as you saw, needs to be replaced every 2 weeks. Don't try to wash it. Don't try to reuse it beyond that. The powder going through the inhaler and into your lungs will get stuck on the plastic, and so it's important to not do those things and move on to a new inhaler every 2 weeks. We've got these 3 different cartridge colors, and you can use them, mix and match whoever you need to get there. And coverage, of course, has been a challenge in the past, but this insulin does often require prior authorization. But there's incredible manufacturer patient assistance programs available right now with the new pediatric indication. Every patient can get coverage with this insulin for $35 a month. And lastly, of course, anytime we're taking care of patients, we really need to include team-based care. Type 1 diabetes is the ultimate team sport in taking care of patients. We need the endocrinologist, the primary care physician. We have to talk with them. We have to make sure we're being clear with our patients. We have to talk with our pharmacist. Obviously, our diabetes nurse educators, as we saw with Zach's case, are going to be really critical in making sure they understand all the details of the PK of these new insulins. Really understanding how to analyze people's AGP reports, and then, of course, looking at their particular CGM use and apps. All right. So finally, if we talk about shared decision-making, when you're having a conversation with a patient like Zach and meeting them where they are, I think all of us are eager to put almost all of our patients on AID, as that is now a standard of care, as Dr. Hirsch talked about. But many of our patients just have barriers, and we really need to meet them where they are and use all of our tools so that we can get patients to goal in a way that they're comfortable doing that. And so patient barriers are, as you saw, that most patients are unfamiliar that inhaled insulin is an option. So that causes a problem. They don't know what spirometry is. That sounds scary. Do I have to go to a pulmonologist? As you saw, it's very easy to do. The patients don't know to ask for it because they don't know inhaled insulin exists. And many patients might come to you with access concerns, but as I've mentioned, there's ways around that right now that are making it quite easy to get to. What the evidence enables, we've seen now really meaningful time and range improvement, both with INHALE-3 and INHALE-1 data in individual patients. We see significant reduction in hypoglycemia that really addresses one of the #1 behavioral barriers. Obviously, not having to utilize a sharp is a huge benefit in many social situations. There's a lot of stigma still around injecting. And I must say that talking to school nurses, they're very excited about the opportunity to be able to give insulin without having to use a needle. The fast onset, fast offset is a huge lifestyle advantage and gives us much more flexibility with insulin than injected. And then again, as we mentioned, the recent FDA approval is very exciting. So offer it, screen for it by talking to your patients about it, teach them how to use it. Don't just wait for patients to ask. This is a really important tool, and we need to be proactive in making sure our patients know it's out there, because for many of them, it will be able to improve their outcomes and improve their care. All right, so 5 takeaways for inhaled insulin tonight. Cough, common, typical, but it is mild and transient. Insulin's in very quickly, absorbs before the cough reflexes does anything. Make sure you let folks know about it. Redosing is very often needed in most patients because of that short duration of action. So because it's gone so quickly, you can give them set numbers for triggering a small dose touch-up. Often people using thresholds of 140 or 160, 90 minutes post-meal. That looked really well in the INHALE-3 study. There's less hypoglycemia, so all these use cases, post-exercise, concerns about nocturnal hypoglycemia, erratic meal timing, all those things can be overcome with the use of inhaled insulin. Spirometry, as you saw, I think that's something that's so foreign to most endocrinologists and patients. They think it's scary. It takes 2 seconds in an office setting. Handheld spirometry meters are easy to obtain. You can give them to the patients to do the testing even at home, as Dr. Isaacs mentioned. And lastly, again, think about it. Think about inhaled insulin. Try and offer it proactively. We need every tool in the toolbox to be able to manage our patients from a whole perspective of giving them all the options. And it's important that they know about the option of inhaled insulin as well. All right, so our second reflection question. Now that you've heard me preach about it, how would you discuss mealtime insulin delivery options with your patients? Think it over in your head, maybe come up with your own scripts for how you would present this to folks, what the advantages are, why they might think about using it. All right, and then lastly, you are able to submit questions through the QR code there. And I think Dr. Hirsch is going to have a Q&A with us using those questions that you enter. And don't forget that you can scan the second QR there for earning your CME credit if you'd like. Thank you.
Great, thank you, Dr. Haller. I have a bunch of questions, and I'm not sure we're going to get through them all in the next 5 minutes, but I'm going to take them in order. And I want to make one other really important point. The 2x starting dose, that is the starting dose. When we went back and in Inhale 3, when we looked back what were patients actually taking, it was actually 2.5. And I believe, and Mike, correct me if I'm wrong, it was 2.9 in Inhale 1. And so the 2x dose is actually a conservative dose. It's certainly not the ending dose. And I can't imagine anybody would see hypoglycemia with that. Okay, so with that, I'm going to start with the questions, and I'm seeing them also for the first time. Okay, so Mike, this is, I think, for you, or for both of you. Are there any different considerations for pediatric use of inhaled insulin that are different from use in adults?
I'll just say that my bias was I didn't think that the young kids could do this well, but actually they did incredibly well with it in the Inhale study in kids. So they had to do full PFTs for the research part of the study. Obviously, you can see clinically all they have to do is the FEV1. Kids were able to take it really well. They had a low index or a low incidence of cough actually compared to the adults. So there really wasn't any major hurdles other than our own biases not to think about starting it. So I'm excited now that we have the label to be able to offer it to more of those patients.
I'll just add, I think just thinking about school-age kids and eating lunch at school and kind of timing that insulin. So with injectable insulin, you could go to the nurse, inject it, then go to the cafeteria. We shouldn't do that, right? This starts working right away. So it's really important to dose it either as food is being eaten or even right after would, in my opinion, be safer.
So that actually was going to be my question. And in Inhale 1 or any other experience, do kids go to the nurse or do they, because as many people know, I have a nephew with type 1 who was school age at one time, not anymore. And I'm just curious the logistics of doing that.
Yeah, no, we learned that exactly as Dr. Isaac said. So we did have a kid in the study who had to take their insulin at the nurse and then walk far away to get the meal. And that timing was because the insulin is so quick, didn't work well. So you do have to think about the logistics and sometimes adjusting for that. There are going to be situations where you may need to take the insulin immediately after eating or make sure that the kid can get it right when the food's in front of them. So you do have to think about those issues as well, but we were able to overcome those and the kid continued to do well.
That's fantastic. Okay. It was mentioned that it needs to be refrigerated. This is for you, Diana. How long can it go unrefrigerated when carrying the blister packs?
So I believe it's 10 days outside of the refrigerator. If you have just the open packs where you've taken them out of the container, then it's only 3 days. But if they're unopened, then it should be 10 days.
Great. Okay, next question. How does this impact something like Control IQ, where the pump adjusts and corrects for you? Seems like inhaled insulin for corrections may interfere with the Control IQ technology. Who wants to tackle that first? I mean, I
love this question.
I will start. I wish we had more time. A dear colleague of mine, it was his son who saw that the inhaled insulin worked great with his control IQ. And we now have quite a bit of experience with that. Obviously, this is all off-label, but this was the question. With control IQ, it actually works extremely well, and my belief is why it works well, even when you do get the correction doses, is because the control IQ is set automatically at a 5-hour insulin action time, which actually, from the pharmacodynamic study I showed you, is about what it is. It is 5 hours. And so it is 5 hours, so the control IQ doesn't see it, quote unquote, and our experience, never formally done in a clinical trial, is it does well. Now, with that being said, I don't have experience or much experience with any of the other AID systems. I would be particularly concerned about using this with an iLet. But with that being said, I'm curious about what the two of you think of this question.
Yeah, I mean, I can go. So I think with auto corrections, right, you got to be a little careful in terms of if you've just got an auto correction and then you inhale and now both of them are working. So a system like Omnipod 5 is interesting because it is based so much on it's based on total daily insulin. So if you end up getting so much of your insulin through inhaled insulin and you're not getting the mealtime, that is going to bring down the TDI, and that could cause the algorithm to be less aggressive. That being said, I ran into someone yesterday that's having a lot of success doing that. So I think it's about kind of figuring out what works for the person.
Yeah, I've had a number of patients have success with using inhaled insulin for particularly challenging meals, even when they're on AID. I think it works best right now with the tandem system because of not being affected as much by total daily insulin. But there are patients who do things like air bolus so that the insulin is accounted for in the system. But most folks have just gone ahead and taken it, let the system run, and because, like Dr. Hirsch said, the insulin action is so long, there just isn't anything as fast as inhaled insulin. And we all know that for our patients who are doing most of the work that they can to achieve good control, that those post-meal excursions are what cause the difference between a normal A1C and wherever they land. And so if you can just use the inhaled insulin as almost a meal announcement and let these algorithms do the rest, I've been really impressed with that. And so I hope that somewhere down the line we'll have Bluetooth-enabled inhalers that can actually push the information about inhaled insulin into AIDs, and those AIDs can account for it. But even now, without being able to do that, I've had patients have great success.
Yeah, it's a really great rescue insulin also. I mean, especially for you just have a stubborn high and it's like you use it, that's not going to impact the algorithm very much, and it can bring down a stubborn high more quickly.
So don't get air bolus confused with air guitar, right? Okay, we are out of time. I'm going to do one more question. I have so many great questions here, but I'm going to do one more even though we're out of time, and I'm just going to pick one. And Diana, you talked about this a little bit. It's a very quick question. Can you take a correction dose at 1 hour and then again at 2 hours if needed?
You could, yeah. So if the glucose isn't responding, it's continuing to go up, you absolutely could take another one an hour later.
Great,
Yeah.
Great, thank you. Unfortunately, we are out of time. There are great questions. I think we'll be here for a few moments. I want to thank everybody for participating. To earn your credit, click on the Earn Credit icon, or you can scan the QR code that's up. It's valid until the 4th of July. And I want to thank everybody for attending tonight. It was great to see many of you who I know, and enjoy the rest of the meeting. Thank you all very much.